Hi and welcome. Dennis Otundo here, and we'll be looking at blinding in randomized controlled trials. So basically, blinding is when the treatment allocation is concealed from either the subject or the assessor or even the board or both. It is done to avoid conscious or unconscious bias in reported outcomes, and therefore a trial that is double blind is neither the subject nor the assessor knows which treatment is being given. And in single blind, if the treatment allocation is concealed from either the subject or the assessor but not both, but in triple blind, it is the patient who is blinded, the investigator is also blinded, and the committee monitoring the response of the variables is also blinded. So why should patients be blinded? Patients who know that they are receiving a new or experimental intervention may at times report side effects, either over-report or under-report, depending on their general view and feeling of the treatment or the experimental intervention they are receiving. And also patients who are not new to a treatment or experimental intervention may at times even report, depending on what they know about the intervention or what they may feel about the intervention. So they may be more or less likely to drop out of the study in some instances, and patients may have preconceived notions about the benefits of the therapy, and also they may also at least try, which is very funny, to get well to please the physicians. So that is the reason why patients most of the times are blinded, but investigators are also blinded in a double-blind study. And treating physicians and outcomes assessing investigators are often the same people, and that is one major reason why investigators are most of the times blinded, and possibility of unconscious bias in assessing outcome is difficult to rule out. And the second reason is decisions about concomitant and compensatory treatment are often made by someone who knows the treatment assignment, and compensatory treatment may be given more often to patients on the protocol arm, perceived to be less effective. So I have two examples. Number one, a subject who knows that he or she is receiving a new treatment for pain which he expects to be beneficial may perceive or actually feel less pain than he would do if he thought he was receiving the old treatment. And on the other hand, an assessor who knows that a subject is receiving the new steroid treatment for chronic obstructive pulmonary disease, which he expects to work better than the old one, may tend to round up measurements for lung function. So when we've talked about the subject and the assessor, if the treatment allocation is concealed, then both the patient and the assessor will make unbiased assessments of the effects of the treatments being tested. And the word here is unbiased assessments. So having said that, we cannot avoid talking about a placebo. A placebo is an inert treatment that is indistinguishable from the active treatment. If you look at the two, that means visually indistinguishable, that means. And in drug trials, it is often possible to use a placebo drug for the control, which looks and tests exactly like the active drug. So the use of a placebo makes it possible for both the subject and the assessor to be blinded. And there are instances where even blinding is not possible, such as in trials of technologies where concealment is impossible. For example, in trials comparing different types of ventilator, it is impossible to blind maybe the clinician, and similarly in trials of surgery versus chemotherapy. And possible solutions are the use of sham treatments, such as surgery that may not be ethically acceptable, and trials of effectiveness of acupuncture may have sham acupuncture for the control to maintain blindness, and trials involving injections sometimes use saline injections in the control group, although this may also raise ethical objections in different countries. There's also an issue called double placebo and active placebo that I want us to look at. And double placebo is sometimes popularly referred to as a double dummy. And if a trial involves two active treatments that have different modes of treatment, for example, maybe a tablet versus a cream, a double placebo can be used whereby each patient receives two treatments. Patients would receive either the active tablet plus a placebo cream, or a placebo tablet plus an active cream. A double dummy can be used if the timing of the treatment is different for the two drugs being tested. Maybe, for example, if one drug is given once a day in the morning and the other is given twice a day, morning and evening. In this case, one group of patients who receive the active drug in the morning and the placebo both in the morning and the evening, the other would receive the placebo drug in the morning and the active drug both in the morning and in the evening. So when it comes to the active placebo, trials may use an active placebo which mimics the treatment in some way, and the main aim of this is to maintain blindness. Maybe if I give an example, some treatments give patients a dry mouth, and so the presence of absence of this side effect may indicate to the patient which treatment they are on. I think that is all I have when it comes to blinding in RCTs. We will definitely come back to this and refer it in later screencasts, but in the following screencasts we'll be looking at parallel groups and crossover designs, which are very popular in randomized control trials. We'll also look at the advantages and disadvantages of both, and later we'll look at the famous Zellen randomized consent design form. Otherwise, thank you for participating. See you.